Awesome. Okay, let's get started. I'm Shannon Gordiola. I'm the program manager at Deep Connections. I'm also a rare epilepsy mom to my daughter Zoe. She passed away in 2024, but I am honored to carry on the work of just helping improve the quality of life for families still, in the trenches of caregiving. And here at Deep, that's what we want to see. We want to see improved quality of life for families. We want to see you guys supported, empowered, and educated. And we're really excited to partner with Families SCN2A today. This topic I think is very popular. We had a lot of interest, and this is something I lived every day when caregiving for Zoe is her clustering seizures and her status seizures, and it's sometimes a very scary place to be as a caregiver. And so we're excited to get into this topic. A couple housekeeping things. If you're just joining, if you didn't hear me say before, we can't see you or hear you. So feel free to care for your child, eat lunch, do whatever you need to do in the background while listening. This is being recorded, so if you miss something, don't worry, we'll be sharing so you can look back at it. Um, and then please feel free to use the Q&A to drop questions into as we're going, and hopefully at the end we'll be able to get to some questions, maybe all of them, depending on how many we get. And anything else, let me see. Oh, I'm about to release some poll questions. If you can please answer them, that would be great. We'd greatly appreciate it. We want to make sure that the webinars we're doing are actually being helpful and impactful to you as a caregiver or a clinician or whoever you are joining us today. So I think that is all, and I'm going to hand it over to Jenny so she can introduce 2A and a little about herself in 2A. So go ahead, take it away, Jenny.
Thank you, Shannon. Thanks for having us here today. I'm Jenny Burke. I'm the board chair of the Families SEN2A Foundation. But more importantly, I'm mom to Alex, a 25-year-old boy, man, I have a hard time with that, who has had seizures since birth due to an SEN2A variant. I think he's had all the seizure types over the years, including clusters and status, and he's still having seizures today. 11 years ago, Families SN2A was formed by dedicated parents who felt all alone in the world and vowed to change things. We've had a mission to accelerate research, build community, and advocate to improve the lives of those with SCN2A related disorders around the world. So educating the community is one of our most important duties, and we take it very seriously. This topic in particular can have a tangible impact on the lives of those having seizures. It's really critical to be able to differentiate status versus cluster seizures and treat them accordingly. And I want to thank the Deep Connections. We love collaborating with you all. Thank you for hosting. Thanks for our SCN2A warrior families for generously sharing their time and their stories today. And to Dr. Hughes and Dr. McGarry for being champions in our community. They're both very familiar with SCN2A and personally manage care for many people in our community. So thank you, and I hope we learn a lot.
Yes, I'm excited. Jenny, you want to introduce our parent voices?
Sure. Remind me what order we're going in
I think
here.
either works fine.
Okay.
I'm not sure if Jake's
Um,
joined yet.
uh, can't see them all. Renee Hughes. Renee Holmes. um, is a mom to also an adult, Carson, who has seizures. And I actually feel more comfortable letting them introduce
Yeah,
themselves.
let Renee
So
tell
let's do
tell us
that.
about
Yeah. And then Tara Adams is our other mom here today. And hopefully we will get the third one on board before the end.
Thanks, Jenny.
I guess you ready for me to start my section here?
Yes, go ahead, Renee.
You're fine. My name's Renee Holmes, and I'm the mom of Carson, who is 23. He started having seizures at 2 days old, and has about four distinct seizure types. He Prior to the last about 2 to 3 years, we were having 50 or more seizures a day. Some days they, would guess around 100. almost anything change in light, in sound, in heat, in anything in his environment that changed would start seizures. Um, again, after, you kind of think, okay, maybe we're done for today, and then obviously you're not. That's kind of the story of our life most days. He was a late diagnosis of SCN2A at 19, and was able to, with a lot of help and direction with the SCN2A Foundation, was able to get into a drug study. And so we're doing better. We still cluster. And most days that we do have seizures, we do have clusters probably more than 50% of the time, but those do look a little different than they did when he was younger. He loves anime. He loves dressing up like anything and everything he can possibly dress up to be, and we just agree, yes, that's exactly what you look like today. And he works at a local library a few days a week, and they have the most organized library you've ever seen. And he is proud of that. He is served in our state's home and community-based waiver, and so has home-based supports that are there with him now because I'm working in Memphis today, and so y'all are zooming with me from the car outside of a clinic in Memphis. So we're excited to be here and excited to learn some new information, and anything is always helpful. Anything I didn't come into learning today, I'm excited to learn. So I appreciate you for having us and inviting me today.
Thanks, Renee. Tara, we'd love to hear from you.
All right. I am Tara Adams, mom to Abby and Kinsey. They both have epilepsy and they both have the same SCN2A variant. My oldest has some of the autism-like traits from the SCN2A variant, we believe, and she also has epilepsy. She never had status or clustering, so I did not know what that was going to look like until my youngest started having seizures. And she has, not that we know of, has she ever had status, but she does have clustering. We did not know that there was a treatment for clustering until we went to an expo 2 years ago, and we've talked to some doctors there, and they told us that we needed to have an emergency medication. And so that's what we tried. And sometimes we wait longer than others to give her medication. Sometimes we give her medication quickly, depending on what her clustering is looking like. I'm very excited about this webinar because I feel like I don't have a lot of information on when I should do things and how I should do things. And it's been a very kind of like trial by error for us that we're trying to figure out how to treat her clusters, how to when is the appropriate time to treat her clusters. She has absent seizures that cluster, and we don't usually treat those. So she'll cluster for sometimes up to 2 hours. And I just don't know when I'm supposed to give it to her. And then she also has atonic seizures, and they will cluster as well. And so she'll lose consciousness and all body tone, and then she'll come out of it and she'll be aware, and then she'll do it again and she'll do it again. And so that's usually when we will give her emergency medication. But like I said, it feels like trial by error. So I feel like this is going to be such a huge help for my family in giving us information on how to do that and what it look like, what the difference is between status and the difference between clustering. It's going to be such a huge help for our family. So
Well, I'm excited for you to learn today too, Tara. I feel like, yeah, this is going to be a great topic. So I'm going to stop sharing my screen so we can allow Dr. Ina and Dr. Laura to share theirs. Um, I don't know, which one of you want to go first to share, introduce yourselves, and then we'll go into the slides. So, Dr. Laura, how about you? You're the first one I.
Sure. Nice to meet everybody virtually. My name's Dr. Laura McGarry. You can just call me Laura. I'm a pediatric neurologist at the Children's Hospital of Philadelphia. I did my training there, including a fellowship in epilepsy neurogenetics. And clinically, I take care of many children with refractory epilepsy, both with a known diagnosis, particularly SCN1A, 2A, and 8A, but also many children who don't have a yet identified genetic diagnosis. And I also do some basic science research trying to understand how in different genetic conditions, the mechanisms of both epilepsy and other related symptoms that come along, like autism spectrum disorder. So I'm really excited to talk about this topic with you today, because it's something we talk about all the time in the clinic.
Awesome.
I am Dr. Ina Hughes from Pediatric Neurology and Peds Epilepsy at University of Rochester in Rochester, New York. My practice is also, like Dr. McGarry's, primarily in kids with really hard to control seizures, and we have just had the joy of having lots of kids in our practice with developmental epileptic encephalopathies and different types of hard to control seizures from a variety of different rare diseases. And again, some that we know of and some that we're still working on understanding. And then a lot of kids with acquired epilepsy syndromes from things like hypoxic ischemic injury or other reasons why brains might have complicated seizures. And I work as the co-director of our ketogenic diet program. And my interest in research is both on helping kids with the transition from peds to adult world and on helping to kind of optimize different ways of doing the ketogenic diet for kids as well.
Awesome. Thanks so much for both of you being here, working so hard together to bring all this information to us. So we're excited to get started. I'm going to go off screen while you teach, and I'll be in the chat if anyone has questions. And once again, use the Q&A if you have questions too for the end.
All right. So hopefully everyone can see the slides. While we're going to talk about some things about the idea of seizure exacerbations, clusters, acute repetitive seizures, status epilepticus, really what we're going to be talking about is the idea of how do you decide when it's going to be a bad day, when it's going to be a trip to the hospital, and when it's going to be time in the ICU, and kind of what plans can be made to help make those as smooth experiences as possible. So we're going to talk a little bit about the definitions themselves and talk about the complexity of some of those things. And then think about the difference between status epilepticus and acute repetitive seizures or clustered seizures, which sometimes get used interchangeably, and considerations of those that are specific to the developmental epileptic encephalopathy patients. And then we'll give you some specific concepts of how to build plans for bad seizure days at home and in the hospital, and kind of go over a case example that some of you may have also experienced, and we can talk about it a little bit more at the end. One of the things to think about is just some of the definitions. So everybody with epilepsy at some point will have a discharge in their brain. A discharge is basically the smallest amount of abnormal electrical activity that is not that well-regulated, tightly controlled electrical activity that we expect to be in a typical brain. And it basically will look like this on an EEG, just kind of sharp, spiky thing that is happening on the order of milliseconds. And on the whole, a discharge all by itself is not a problem for most people. For most people, a discharge is a single event that just lets us know that our brain handles its electricity differently. When discharges come close enough together that they actually start to disrupt what the part of the brain that is having the discharges are doing and alter the way that the brain is functioning because of those discharges, that's when we actually think of it as a seizure. And for instance, here's a very tiny version of a seizure on an EEG. And seizures can last anywhere from, most of our definitions say 10 seconds up to status epilepticus, which we'll talk about the definition in a little bit. And we tend to think of the longer a seizure lasts, the more total seizures you have in a day, kind of the higher risk of injury for somebody. But there are some special characteristics for people with developmental epileptic encephalopathies where we know that their brains kind of also sort of know how to have seizures and can recover from them a little bit faster than someone who has never ever had a seizure in their lives and whose brains have no mechanism for recovery. And so that's actually one of the first reasons why people with developmental epileptic encephalopathy are a little bit different when we're trying to make these decisions between, are we looking at an isolated seizure? Are we looking at recurrent seizures across a day? Or are we getting into that place where we start to worry that there's a potential for injury as someone accumulates more and more seizures over a day? or the seizures become particularly long. The idea of status epilepticus is that there is actually a definition that is agreed upon by this group called the International League Against Epilepsy. Interestingly, the timing isn't always agreed upon. Are we going to call it greater than 5 minutes, greater than 10 minutes, greater than 30 minutes? In general, across the world now, we say that a single prolonged convulsive seizure lasting longer than 5 minutes starts to count as status epilepticus, which means a state of being stuck in seizure. And there's this kind of little asterisk that said, or repetitive seizures where you're not coming back to yourself in between. And there's kind of this thought process of kind of how we put this together when we're thinking about treating it as someone comes into the hospital. So in that first 5 minutes of seizures occurring, we call that impending status. And every hospital across the United States at least has a plan that exists and has a protocol for managing when someone comes in status epilepticus. In general, that first 5 minutes of a continuous seizure is treated with a benzodiazepine. So there are a bunch of different medications that we'll talk about, but traditionally there are things like diazepam, lorazepam, midazolam that are available in a variety of different ways to give to people. And once you know that someone is stuck in a continuous convulsive seizure, for most people, that is an urgent emergency, and they're going to end up coming into the emergency room. And our goal is to treat them at home, then potentially have to retreat them in the ambulance. And then once they get into the emergency room, the goal is to start to give them anti-seizure medications, and then to potentially get them to the ICU if those anti-seizure medicines are not stopping the seizure and someone continues onward. And so these typical hospital-based treatments, they're targeted really to someone having a single continuous seizure that isn't stopping. And it's almost always built for people who have very rare seizures or in fact have never had a seizure before. And one of the things you guys had asked was, what is the actual definition of things like, when do we decide it is a cluster of seizures? When do we decide that it is an acute repetitive seizure? And the difficult thing is there is no definitive agreed upon diagnosis and specific time when someone meets that criteria, in part because everyone who has those kinds of seizures can be incredibly different. There have been studies that have used rules that are now sort of being adopted that can say greater than 2 seizures in 6 hours or greater than 2 seizures in a whole day. And for people who have very rare seizures, acute repetitive seizure definitions of 2 to 4 seizures in less than 48 hours can be appropriate. But when we think about kids with developmental epileptic encephalopathies, sometimes the answer is 2 to 3 seizures within an hour or 2 to 3 seizures within 3 to 4 hours. And that variability is appropriate because our kids and our adults who have these conditions can be so very different. The thing that we're trying to figure out is, are these seizures becoming harmful for someone? Are they having enough time in between them to recover? And if they're not, then when do we intervene? The idea is that the more seizures someone has closer together, the higher likelihood that they may transition to that status epilepticus continuous seizure pattern, but is not guaranteed. So our best data about what status epilepticus looks like, or acute repetitive seizures look like in kids with DEE, comes from a research study that was published by the Pediatric Status Epilepticus Group, the PSERG. And when they took 845 kids across, I think, 20 institutions that were presenting in status epilepticus over a 2-year period, they found that only 51% or 51 total of the kids out of that 845 were DEE kids. Which means that the majority of people that were presenting were people that either had relatively well-controlled epilepsy or they were people who had never had a seizure before. And so most of those people would be appropriate for that status epilepticus pathway that is typical for the hospital. But of those 6% of kids that had DEEs, only 24% of them presented with continuous seizure activity, and 2/3 or 3/4 of the kids presented in acute repetitive seizures. Just thinking about the kind of things that cause those seizures to occur, a lot of it was systemic illness. So we know that when a kid with epilepsy gets sick with something else, they have a lower seizure threshold and are more likely to have groups of seizures. We know that about 10–15% of the time that if we're changing medications around, we have a risk of precipitating seizures. And a lot of the times it just kind of happened out of the blue. There are other things that we know can trigger seizures for everybody, including having cruddy sleep. For those who are experiencing menstrual cycles, that different points of the menstrual cycle can be increase the likelihood of seizures for certain people. And that we know that metabolic disturbances like shifts in dehydration, in feeding, and all different kinds can then trigger seizures as well. And one of the considerations that we have when kids with developmental epileptic encephalopathies present with a status epilepticus or acute repetitive seizures is that they may have multiple seizure types. And they may be, as one of the moms mentioned, having absence type seizures, and that may have a different pathway for treatment than if they're presenting with convulsions or atonic seizures. And then the patients with developmental epileptic encephalopathies are often on anti-seizure medicines that may interact. It's also really important to know for our SCN1A families that almost every single hospital's primary treatment for status epilepticus is to use phosphenotoin, a medication that is not recommended for kids with SCN1A related epilepsy, and that there should be other treatments that are there for them. And then patients with developmental epileptic encephalopathies can also respond very differently to anti-seizure medicine treatments for status epilepticus, and we'll talk about that as we kind of go through. We wanted to give you guys kind of an example of the things that we as physicians are thinking about when someone is presenting in status. As we talked about, a kid can present with multiple different seizure types, and which seizure type are they having that they seem to be having lots of? And are we going to treat that slowly and gradually, or is this something that is escalating and affecting their breathing, their heart rate, their respiratory ability, their ability to function in a different way than a convulsion might be, for instance? Are the seizures each very, very short with recovery time between them, or are seizures occurring continuously and lasting for long periods of time? Are the seizures coming very close together, or are they kind of spread out over the day? And I'll show you kind of an example of how we think about that. And then how is someone recovering from them? An atonic seizure that someone immediately bounces back from and is able to return to their day may not be something that we worry about as much, other than maintaining someone's safety during the time of the atonic seizure, as we would if they were having an atonic seizure and then just being really tired and not able to recover. And so this is going to be our little symbol set for different types of seizures. And I'll show you guys again in just a sec, kind of what we think about it. So do you want us to throw something in, Laura? Sorry. I thought I saw your hand go up. So we know that it's not only the number of seizures, but the features of a seizure that kind of can distinguish a typical day from a bad day. And so for someone with relatively well-treated epilepsy, with relatively tractable, so able to be treated by medication epilepsy, they may have, 1 or 2 seizures a month, 1 or 2 seizures even a day. But for kids with developmental epileptic encephalopathy, we know that, for instance, 25 seizures could be a pretty typical day, with a mixture of seizures like brief eye-opening and stiffening episodes out of sleep, staring type seizures, generalized tonic-clonic seizures, and partial body seizures occurring. But if they're spread out throughout a day during times when the child is able to reboot and recover after a nap, or during times of relative calm for them, that even the high number of seizures does not necessarily impact that child more than is typical for them. But on the other hand, if they're having seizures that are kind of back to back, where there's no opportunity for them to recover from, then this would be, for instance, a pattern of seizures that for this kid, if this is where they normally lived on this first line, that even though the number of seizures is similar, the type of seizures and the frequency of them all jammed up close together is something that we want to intervene on. And then later in the day, for instance, the child had another cluster of generalized tonic-clonic convulsions because they're coming so close together that there's no recovery period in between. A different kind of model for when a bad day is something that's probably going to need to have interventions is when you start out kind of with your typical pattern, but now seizures are suddenly coming closer together, and each individual seizure is getting bigger and lasting longer than the one after it. or the one before it. And that combination of things is something that also suggests that this would be a pattern that we would want to intervene on. One of the things that's also really important is even a single seizure can give you a really bad day. So for instance, if you have even a relatively small seizure for someone, just a partial body seizure, but they don't return to their baseline entirely and they're not able to get back to themselves, and then they have a difference with how they're breathing, how their heart rate is doing, they're starting to vomit, they're having a fever. This can be enough to initiate a rescue protocol and to get someone to the hospital on that day because so basically everything actually is context dependent and not necessarily specific to a number or type of seizures, depending on the kid and the situation that is their typical seizure pattern. And so I was going to hand it off to
Yeah,
Dr.
I'll take over from here. So as we were talking about, there can be multiple different patterns that could be the signal that there are worsening seizures, and we should start thinking about intervening. So I'm going to talk now about like what will the plan be when a bad day is something that we need to intervene upon, and what types of plans should we have in place. And we're going to really focus on the idea that there should be multiple plans. There should be plans that could take place outside the hospital, at home or school, with the goal of preventing a hospitalization if it's not necessary. And then also when coming into the hospital is necessary, there should be a different plan in place, right? Because that is a different scenario than seizures that could potentially be treated at home. So fortunately, we have many different options for treating seizures that have rescue medications that have increased in how we can give them compared to, say 10 or 15 years ago when there were limited formulations for these rescue medications that could be given at home. So at home, the most common type of rescue medication that is given is a benzodiazepine. This type of medication works on the brain's innate inhibitory system. That's the brakes on this electrical activity that generates seizures. And those are medications like midazolam, diazepam, lorazepam, clonazepam. And they come in different formulations. So we currently have nasal, intranasal sprays, Nasalam or Valtoco are the brand names, rectal formulations, Diastat. Both of those different formulations are going to have a fast onset that can be really helpful when there's a escalating tempo of seizures or a prolonged seizure going on. We also have different oral formulations, both of benzodiazepines, so medications like clorazepate or Transine or clonazepam. Those will have a little bit slower onset, so they might be better suited to more simmering uptick in seizures. And then there's also sometimes plans that can include extra doses of a daily anti-seizure medication that a patient is already on. We'll talk a little bit more about how to craft this plan for each individual situation. There's also plans that should be in place for when going to the hospital is necessary. In the hospital, both in the emergency room and on the floor, IV medications are most often used. So those can include IV benzodiazepines, so lorazepam, midazolam, and diazepam, and then also a whole number of anti-seizure medications that can also be given IV. And so some of these medications can include levetiracetam or Keppra, phenobarbital, phenytoin or dilantin, valproic acid or Depakote, and lacosamide or Vimpat. And all of those medications, one could be medications patients or children are already taking. Two could be medications that might be ones we want to avoid in certain scenarios, or we might know for a particular child that there's certain medications we should use earlier than others. So we'll talk a little bit about that. And then if, like in our example, where this treatment both outside of the hospital and in the emergency room has not addressed seizures, sometimes we're moving to the ICU. And there, continuous IV infusions of medications are sometimes used. And these medications are actually anesthetic infusions that have particular considerations in children with DEEs, where we really want to avoid over-sedation and consider both the risks of not treating and the risks of treating. So we're going to talk a little bit more about some of these concepts. So first, I wanted to introduce the idea of a seizure action plan, which I'm sure many of you are familiar with. And this is a plan that gives an outline of what to do when there are worsening seizures. And so the first part of this plan that's really important is delineating what the seizure types are. And so I've filled out this seizure action plan for the example patient that we just talked about, who has 4 different types of seizures. And it's important to include information about how long is a typical seizure for each type, right? And we can see that for some seizure types, the typical length is on the order of seconds, while other on the order of minutes. How often are those seizures usually happening? And what happens when a seizure occurred? And so this is sort of a table format of that sort of picture format we gave before of how seizures look over a day. This plan can be helpful for you as the caregiver at home, but it also can be really helpful for either the school setting or if your child or loved one is with another caregiver. And that's where I think having this sort of very straightforward information about how to respond to a seizure, not only with medications, but with a basic first aid response can be really helpful. So it includes information about what to do when a seizure happens, which includes staying calm, timing the seizure, making sure the person is safe from anything in the environment that could hurt them, not to put anything in their mouth, turn them on the side if possible, and to stay with the person. You can include additional information that might be relevant. For example, does this patient have a vagal nerve stimulator that could be swiped during a seizure? And then also include information on when to call 911. Right? For sometimes we can intervene and not have to go to the hospital and not have to call 911. And then there's other times where we need more help. So if we go on to the next part of the plan, this will now indicate what the rescue therapy or medication interventions can be. And it's important to talk about when and what to do. And you'll see here that there's actually multiple plans included here because this patient has multiple types of seizures. And when we intervene for an individual seizure type is different. So in the first line, you can see this is talking about status epilepticus in terms of a continuous seizure. For this patient, if they're having a GTC or focal seizure that lasts longer than 5 minutes, they should be given their Valtoco rescue. And that can be repeated if that seizure does not stop. The next 2 lines are talking about different examples of acute repetitive seizures or clusters. And you can see that the definition of cluster is different depending on the seizure type. So if they have more than 3 generalized tonic-clonic seizures in 2 hours, they should be given a rescue of Valtoco. And then for tonic seizures, if they have a pattern of more than 6 in an hour that lasts for more than 2 hours, actually instead of their benzodiazepine, they should be given an extra dose of an anti-seizure medication they're taking. So this is just an example to highlight that this is not going to be just one plan. There's actually multiple plans because of different seizure types. There's a plan for status epilepticus, and then there's multiple plans for different types of acute repetitive seizures, and the medication or intervention can be different for those different scenarios. So how do we actually come up with this plan? This is something that is going to be an iterative process between you and your neurologist that should be an open dialogue at your appointments, where what the caregiver and patient can bring is their reporting on like what does a typical day, a typical week, or a typical month look like. This is where a seizure diary or a tracking app or calendar can be really helpful in terms of saying for each seizure type, how often are we seeing them? And what is the impact of those seizures? So what is an acceptable week look like for us? What does an acceptable day look like for us in terms of different types of seizures? And how do those look over time? This can then, in conversation with your neurologist, help build a picture of when is the time to intervene, which will depend both on the baseline or typical seizure pattern and the impact of either prolonged or clusters, acute repetitive seizures. Some other things to include in that discussion are known triggers, which can help in generating a sick day plan that we'll talk about in a little bit. Making an agreement on the cluster. As we talked about, there's no standardized definition. So what is the definition of a cluster for your child or loved one? What is the impact of those seizures? And then do we know anything about their previous response to rescue or bridge medications? This then can lead to the development of these plans, and some additional topics to discuss include avoiding oversedation, how to personalize those medication plans. So if your child has a specific genetic diagnosis, particularly related, as we talked about, to some sodium channel genes, there may be certain medications that should be either avoided. In other conditions, there might be other medications that we want to use first. And then also the use of EEG. When you come into the hospital, oftentimes and medications are being given, the question is, will EEG help us, or is that something to be avoided? And part of the issue there can be that in many children with DEE, the baseline EEG has many of those discharges or brief electrical events. And sometimes, if those providers are not familiar with what that baseline EEG looks like, that can lead to over-treating or treating things that are actually just the baseline EEG pattern. So there's a few more considerations on the next slide. So in terms of a sick day plan, this would be a plan for a bridge or a short course, say, for example, 3 to 5 days of additional medication given once a day or twice a day to help at times where there's an increased risk of seizures. One of the most common ones is actually, as the name suggests, when a child is ill. So it's important to understand what are those symptoms. Is it just fever? Or are there other symptoms that should trigger starting this plan? And then for, obviously we can't avoid illness, especially children of all ages, but particularly our younger children, right? They're getting viral illnesses quite frequently, but there are some triggers that we might be able to predict or avoid. And some of those could include, for children who have temperature sensitive seizures, getting a cooling vest. For our older girls and women who have menstrual cycle related seizures, whether some hormonal contraceptives should be used to suppress the cycle to minimize seizures. So it's not only anti-seizure medications, but other interventions that could address the trigger itself. Then there's the rescue plan, which we just walked through. One consideration is that sometimes patients may have a different plan for school versus home. So that's something to think about, this setting in which seizures are occurring and how that affects actually the impact on their child and their function. Also, how to contact your neurologist. If you've started to put the rescue plan in place for a cluster of seizures and it seems like things aren't going the way you might hope, how can you get in touch with them if you're not at the point where you feel like you need to go into the emergency room? And then finally, when to just call 911 and go to the hospital directly. Once you're in the hospital, in addition to thinking about medications that might be either beneficial or to be avoided, also think about what workup is needed. In some hospitals, if a child is coming in with worsening seizures, they will just automatically try to get a head CT. And that may not be necessary for your child if they are a child who has frequent seizures that are difficult to control, but doesn't have a history of injury or other provoking factor that would necessitate head imaging. And then finally, how could a local hospital contact your neurologist, especially if your child is staying for a longer period of time? Is there a way to get in touch with the provider that knows them best? If this has gone on to require ICU, again, thinking about medications that should be avoided in the setting of continuous IV infusions. We'll talk a little bit at the end about some evidence that IV medications, anesthetics could actually worsen seizures in children with DEE. So there's a fine balance between treating seizures and trying to not worsen them or cause side effects. And this is really where the question of, does your child need EEG or should that be avoided, comes up. EEG is almost always or is needed when we're doing continuous IV medications, but it's really important to understand what is that child's baseline, what should be treated on an EEG, and what is really impacting the patient and requiring treatment. So again, these multiple levels of plans and multiple different considerations at each level. And then just to say, as we talked about at the beginning, all hospitals have a plan for managing status epilepticus. If your child is experiencing a continuous nonstop convulsive seizure, that rescue plan in place at the hospital is most commonly the correct one to follow. And if a child presents in continuous convulsive status epilepticus, the hospital will be implementing that plan, sort of continue, like they're very efficient at doing that because that truly is an urgent and emergent situation that is a bit different than acute repetitive seizures. So we'll go now next into a case that will highlight some of the things we just talked about.
And so in the setting of having kids with DEEs, this is an example of a 14-year-old young patient with a care plan that was actually complicated because people didn't entirely recognize that this was a patient with a developmental epileptic encephalopathy and thought this was someone who almost never had seizures, which was actually not correct about the patient. They were a person that was on Keppra, Depakote, and lamotrigine at their baseline. And a new provider that they had just received had switched them from immediate release lamotrigine to extended release lamotrigine, and the pharmacy didn't have that medicine, and so they ended up missing medication. With this, they started to have multiple small, brief seizures that were kind of arising out of sleep and causing them to stiffen and get tonically stiff. And then they started to have kind of bigger and bigger seizures over the course of the day. And were brought into the emergency room kind of right around here when the family recognized that this was very far out of their norm for the frequency and how close the seizures were getting together. And while in the emergency room, had this bigger convulsive seizure. And followed the pathway of having treatment for that big long seizure. Initially was given IV lorazepam, and when that benzodiazepine doses didn't help them, and they continued to have recurrent seizures and convulsive seizures, and then as soon as the convulsive seizure was over after 15 minutes, they started to have additional seizures. They were given some additional Depakote, and then a little bit later, additional phosphonatoin, and then became so sleepy that people were not seeing the seizures on their body. And there was a concern they were having seizures that were not visible to be seen because the anti-seizure medicines reduced how their body was responding to the seizure. They were taken to the ICU, and so the continuous EEG was started. And while this is not what EEG typically looks like, I'm going to show you something called, first we'll start with the regular EEG. So many of you have probably seen EEG for your children. This side and this side of the EEG are more on the typical part of what we expect to see on someone who is not actively having seizures. And this bit, which is helpfully labeled as seizure, is what we would see in someone who is having the kind of seizure that causes their body to become stiff all over. And this pattern of EEG was able to be picked up by something called PERSIST, which is a type of computer pattern that allows everyone, even those who are not reading the EEG itself, to recognize when seizures are occurring. In this case, all of these little red dots were brief seizures that were occurring on this person's EEG as they started their time in the ICU. I wanted to show you this pattern. The patient had received IV medications, which helped to break up some of their seizures. And each of these red columns were brief individual seizure patterns that were occurring for this patient. And because of the previous treatment that they had received, they were not actually experiencing those seizures on their body, but on the inside of their head during this part of the EEG monitoring. And because we recognized that seizures were still occurring, this patient received a big bolus, large volume of a medication called midazolam, and then was started on an anesthetic drip with midazolam, which is a type of benzodiazepine. And during that brief period when we started the medicine, we actually saw seizures get better. And we hoped that that person would be able to have a significant improvement in their seizures and be able to come off of that medicine. But after a period of time, the pattern reemerged. And each time someone gave them additional doses of midazolam to try to prevent these brief seizures from happening that were not affecting their body or their heart rate or any other pattern, but are something that we often can see in kids with developmental epileptic encephalopathies, the seizures actually increased in frequency and started to affect the person more in the sense that their brain wasn't able to rapidly return from that pattern. And one of the things that was important for this patient was recognizing that this was a pattern that was actually being caused by the medication, as opposed to a pattern that was being caused by the patient's epilepsy, and helping the patient to come off of the medicines that were keeping them too sedated and too sleepy and to wake up.
I think one key theme that's emerged, should we have a different approach to treatment of status epilepticus or acute repetitive seizures in patients with DEE? I think the answer is clearly yes, but why don't we have just guideline treatments of like what exactly we should do? There's no nationally recognized guidelines for the management, but many groups have recognized that some of the issues we've talked about today, that overtreatment should be avoided, that some of the treatments might actually make seizures worse. And the reason we don't have these guidelines is not that people aren't thinking about this or trying to do this, but that it's actually incredibly complicated, because each person is individual. And actually, what we're learning is that we have to treat them as that individual. We have to recognize what their baseline typical pattern is, right? A typical pattern for one child might be something that another child is being treated for. And that's okay. We want to make sure that we're tailoring the treatment to the child, and that's going to be what allows us to avoid things like overtreatment and excessive exposure to the risks of those treatments. But because this is a balancing act between risk of treatment and risk of seizures for each child, it's really hard to make standardized guidelines. But I do think that there are some things we can standardize, which are one, standardizing the fact that everyone should have these plans in place, that this should be part of their conversation with their neurologist, and that these plans should span multiple levels. So from the plans at home, which can include a sick day plan to prevent seizures during high risk time, to different tiered approaches to escalating seizures like acute repetitive seizures and status at home with when to treat and what medication to treat. And then a hospital plan that includes both medications and workup, including recommendations on use of EEG or need for imaging. And throughout all of this, as the parent or caregiver, advocating for your child's baseline seizure pattern and really being the one who brings that information to your neurologist to help come up with this shared decision-making and plans, can help create these plans that will help provide the right treatment at the right time for your child or loved one and avoid some of the risks of overtreatment. So I think we're happy now to turn to the Q&A to address any questions. Let me see if I can pull that up now.
Yeah, that was great. While you're doing that, Dr. Laura, I'm gonna give Katie a chance, our other parent voice. She finally was able to join. Sounds like they're
Great.
in the hospital. So I'd love for her to be able to share about her daughter. Hi, Katie. Thanks for joining us.
Sorry, we were in the hospital and it overran, and I had no signal at all. So
We all
apologies.
understand, I think. Yeah, glad to have you. We'd love to hear about your daughter.
Thank you. So yeah, Bella is 8 years old. She was last week. She has SCN2A, and she presents predominantly with days of clusters. And these days are the seizures last pretty much all day long in clusters, and she can have up to 150 very small seizures. And touch wood, we've been very lucky that the tonic clinics that we had years before and status epilepticus has been a lot calmer than it used to be. So we're in a better place there, but we are still having these really hard cluster days.
Oh, thank you for sharing about Bella. Um, so yeah, if you have any, we have a lot of Q&As or a lot of questions
Yeah.
come in. So yeah, parents, feel free to weigh in as these questions come in if you have anything to share as well. I'm going to also release the post-webinar poll question as Q&As are, going on. So I guess we can start at the top. I think Katie, if you can mute, I think I have some feedback. It looks like one of the questions we were getting is kiddos with a lot of respiratory issues. Parents wanted us to touch on how do you kind of the balance of all the benzos and all the rescues, interfering with already hard respiratory conditions. So Dr. Laura, Dr. Ina, if you can weigh in there. I know it's such a balance with a lot of our kids that struggle that way.
One of the things that I think is also important to recognize too is that sometimes dropping oxygens don't always mean that someone is losing their oxygen, particularly if So everybody is different, of course, and kids who actually have lung disease or have heart disease, so differences in their heart structure or whose lungs are injured or scarred or have a difference in how they function all their own, this is a different exception. But in general, when someone has a healthy heart and healthy lungs, if their oxygen is dropping very quickly at the onset of a seizure, it's not because they're losing oxygen to their blood and to their brain. It's actually because their body is clamping down and basically not sending oxygenated blood to stuff you don't need right now, like fingers and toes, where we're typically measuring that. And so if the oxygen saturation is dropping in the first few seconds of a seizure or the first 10 seconds or so of a seizure, that's not deoxygenation. That's someone actually sending all their oxygenated blood to their heart and to their brain and protecting themselves. And so when someone is having a seizure that is lasting into the 3, 5, 10, the prolonged period, and their oxygen saturation is staying low, that tends to be they are actually starting to kind of not run or not have enough oxygen because they are using that oxygen, particularly in a convulsive seizure. And our goal is then to stop the seizure as soon as we can so that they can take that big deep breath and get oxygen moving in their bloodstream again. So sometimes just knowing that those things are true about your kid can help to recognize that that's not the thing that you need to worry about. The oxygen, it's helping the seizure to stop. And then for kids who have respiratory differences or have cardiac differences, that's something that your cardiologist and your neurologist need to get together on to know when is it the right time to provide oxygen and when is it the right time to intervene on the seizures.
That was really good information. I'm curious if any of the parents wanted to weigh in about that. I know I have experience with that, but yeah, if any of the parents want to weigh in on personal experience with that. I can share. My daughter, it's very interesting to say that, Dr. Ina, because my daughter, she would stiffen, and I think that would be and it's scary because you see the numbers, but really it is about stopping the seizure as quick as possible. And then, we would do blow by oxygen or whatever we could while we were stopping the seizure. But then she would take a big deep breath when she had her diastat, administered, and then she'd come out of it. But I think it is like keeping your head on straight, like, okay, let's stop one thing so we can tend to the other things. I think obviously, and you can weigh in as the clinicians here, like obviously if you're having to give multiple rescues, it will like respiratory issues could arise from, you know, being so drugged up that the emergency room probably is your next stop. So
Right. For most people, a single dose of their rescue medication is not going to cause respiratory depression. But as you said, with the combination of ongoing seizure and multiple rescue medications, that can be the case. So I think that's why it's important to have as part of your plan when to call 911 so that you can get EMS services and get to the hospital where if a child does need assistance from a respiratory perspective, that can be provided. Um, so that's always an important sort of tipping point to discuss.
yeah. And the next question I see, and feel free to pick and choose as well, but I know this is a hard topic to talk about, but suit up. What point is suit up at risk? How does it present? Why can it not even be stopped, even inpatient? I know these are probably really big questions, but I think it's important to talk about those risks as well when, you know, seizures go untreated or you're having a hard time treating them. So I'd love to hear your guys' input there.
So one of the tough things is that just like epilepsy isn't a single thing, SUDEP itself isn't a single thing either. SUDEP is kind of a catch-all diagnosis for lots of different things that can happen to our kids. So you can use that term for someone who got stuck in a seizure that we couldn't get them out of. And during that time, it disrupted their heart rate and their breathing so much that they couldn't continue. For other people, it is they had a difference in the conduction of their heart. And when their body was stressed in the setting of a seizure, or sometimes even independent of it, their heart stopped and they had an arrhythmia associated with either having a seizure or sometimes not. It's a part of their underlying diagnosis. And then we've also had SUDEP be described as something that happens when someone has a seizure, but for instance, is turned into a pillow or can't rescue themselves from a situation where they got hurt. And those things all count as different forms of SUDEP as well. And so things like recognizing when arrhythmia is happening in the setting of a seizure is really hard to do if you aren't already monitoring someone and looking for it, for instance. And how we think about it is helping somebody to, one, recognize when seizures are occurring so that seizures aren't occurring in a space where no one knows that they need to intervene. Making sure that someone is safe as they can be in the setting of a seizure so that they're not going to face plant into something that someone's going to recognize if they are in a situation where they need help. And then recognizing that we're trying to make sure that we're not doing anything that increases the likelihood that someone's not going to be able to control their breathing or control their heart rate. So not giving them medicines that could make an arrhythmia worse, not sedating them so much and that they can't breathe on their own, and then not finding a way to give them support. And anything else that you can think of that I'm missing, Laura?
Yeah, and I think your question is something that is an active area of interest and research, and it's definitely something that the epilepsy field really wants to understand better. But I think both because it is something we want to be aware of, but is a relatively rare occurrence, and also despite it having one name, like we just discussed, is actually many different things. So studies that lump it all together because it's rare, so you lump it all together, so you try to learn more about it. Sometimes makes it complicated to make across the board conclusions when it's actually multiple things that are lumped together as one thing. So again, I think understanding, like talking with your neurologist about like what is my child's individual risk, and then what can we do in terms of both epilepsy management and then in the environment reducing risk, which can look like seizure detection and just preventing dangerous scenarios from happening.
Yeah, that's all really great information. We do have a lot of like kind of personal, like people are
Mhm.
asking about personally, like this is what they deal with. So I don't know if you want to tackle any of those, obviously maybe making them more general, but um, I know, sorry, I'm like kind of scrolling through. Also,
Yeah,
are we
I
able
think I
to
saw
share? Oh yeah.
two things that came up sort of maybe across multiple questions were tonic seizures and focal seizures and how those relate to the definition of status epilepticus. So actually, the case that we talked about was an example of um, a patient having frequent tonic seizures and tonic status, which is kind of a separate entity from a continuous convulsive status epilepticus. Sorry, this room is talking to me. And it has its own unique treatment considerations, which include really making sure that we're avoiding over sedation, which could worsen tonic seizures. So I think that may address a couple questions there. And then the question about when is status epilepticus for focal seizures, especially with focal seizures that have intact awareness. The definition is a little bit debated, but seems to be longer than the cutoff we would use for an unaware or convulsive seizure. So that may be reflected in the plans of when to intervene upon those seizures.
Yeah, another one, which I think you guys answered this in your talk, but um, we try to avoid the hospital at all costs. How do we determine how many rescues we can give at home before going? And how do we make sure the hospital, emergency department, and ICU don't use rescues that we know don't work? Which is what you guys talked about, having those plans in place, talking to your neurologist beforehand, before you kind of get into a situation where you're going, what do we do?
Mhm.
Having those plans already written up. So if you have anything to add to that.
Yeah, I can just give an example for a patient. I won't give too much details, but just that a patient where there's a certain rescue medication that for them actually makes seizures worse, and they live a little bit at a distance from our hospital, so they aren't presenting to CHOP, they're presenting to their local emergency room. Um, they have a copy of these different plans with them, but I actually contacted their hospital that they typically go to and provided their emergency room with a copy of the plan and sort of a provider to provider justification of like why we would avoid one of those medications that's in their typical list of medications to use. So that's just like an example that may not apply to everyone, but understanding, and this was, of course, after this happened one or two times, that we realized we really needed to go kind of directly to where this was going to occur and put a different plan in place.
Thank you. We have another question. Do infantile spasms get treated the same as cluster seizures, or is this an entirely different category?
So in general, infantile spasms are their own category that um, they are the slowest emergency in pediatric neurology is one of the ways that we kind of treat our resident or teach our residents. It's very important for us to treat infantile spasms, but each individual seizure is not the thing that we are treating for them. It's the overall pattern of the fact that they are having infantile spasms. And so even a cluster of infantile spasms, because the children tend to recover from the clusters very well, is not something that we would give lots of medication for because we actually have studied hundreds and hundreds of kids with infantile spasms and figured out that classical rescue protocols never seem to actually really help. But treating the overall concept of the spasm or the underlying cause for the spasm does help.
Okay, thank you. I like this question because as a parent who's had a child in the ICU for a while, when they're better, their seizure has stopped, they're coming off all those drugs. There's a whole nother scenario too where they're agitated and how do we help with withdrawal symptoms without going back into the same place we just were? And I know that it's like a tricky balance, so I'd love to hear your guys' input on that.
Yeah, I can start by saying there's can kind of be two different types of withdrawal symptoms. One can actually be sort of seizures that are occurring as the IV infusion medication is withdrawn. And then the other can be other sort of either behavioral or like commonly like disruption to sleep with something that we would call delirium in a medical term. And both of those can be really challenging symptoms to manage and can create a lot of confusion. I think maybe one takeaway point is that each scenario is unique, but often continuing the IV infusion because of clusters of seizures while it's being withdrawn is not necessarily the right answer because those clusters can be something that instead should be you can ride them out and try to get to the other side. Otherwise, it creates this cycle of kind of continually going back on the IV anesthetic. And again, each scenario is different. So it's hard to make a guideline that applies to all, but typically the IV infusions we want to have when we start them, we want to have an idea of when we want to lift them. And then during that time, try to manage either those seizures or other symptoms with additional medication changes or other supports during that time to get to the other side.
And one of the things that's incredibly important to communicate to the team that's taking care of your child, particularly if they're not someone that already knows that you and the child well, is, my child's typical seizure frequency is 10 to 15 seizures a day. So the fact that they're coming off of medicine and just had a seizure doesn't worry me. Why does it worry you? Because that's something that in general, remember how I showed you of 845 people presenting with status epilepticus, only 51 of them were our kind of kids. And so when most physicians are dealing with people in status epilepticus, their goal is to make sure that that person never has another seizure in the whole history of ever. And that's not practical for our people. And so that recognition of when do you feel uncomfortable about your child's seizures occurring as they emerge from anesthesia, as they emerge from the anti-seizure medications that they needed during that bad moment is going to be a really important thing to work with and to work with your epileptologist to have them teach other people as well.
Yeah, and I would love for any of the other parents to weigh in, but I've been in that situation where we're better, we're on our way to go home, we're weaning the IV stuff, and there she has my daughter had a seizure, a bigger seizure, and they were like, "Oh, let's put her back on this," and I was like, "No, this is her. Come, like it's okay." And I wasn't worried, but they were, and I had to remind them like you have to push back sometimes, and that's I think was one of the points of this webinar is to give you the parents tools to understand and be advocates for your child and your family so you feel empowered to do a little pushback. And you can just say, Dr. Yuna said I could, so. But we're over time already. I don't want to keep everybody. This was a really great topic, and thank you guys so much for being here and working together to get this all done. Thank you to the families for sharing your stories. We will be sharing the recording soon. And then are we able to get the copy of the slides? Everyone's asking. Are you guys willing to share the copy of the slides as well? Okay, so we
Yes.
will have those for everyone. Don't you worry. Thank you so much for everyone being here, and hopefully everyone has a great Wednesday and a very relaxing Memorial Day weekend coming up. So thank you all so much. And thank you to Families SEN2A for collaborating and bringing this great idea and finding the families and the clinicians to help us make it come to fruition. So thank you, everybody. Have a great Wednesday.